All right. Hi, everyone. My name is Usama. And we're going to talk today about Kawasaki disease. I'm sure everyone has heard of Kawasaki by now. But the main point of this presentation is to actually point out how challenging can be Kawasaki presentation, because we have this complete picture that was a textbook described fever and multitude of other clinical features, but it doesn't always present this way. So why so challenging for Kawasaki? Anyone knows, just actually had like said something about it, but anyone else knows why it can be so challenging? Kawasaki presentation, to identify a case of Kawasaki.
It shares a lot of features with like an aseptic picture.
Exactly, yeah. Anyone else? Anything else?
They don't all have all the features.
Yeah.
And you've got this new thing called atypical, which...
Exactly, atypical or incomplete Kawasaki, which we are going to shed light on. And it's also, one of the things is that it also doesn't have a specific lab test to detect it. It's mainly clinical. And as Esther has said, most of the clinical features actually share a common, even more common pathology or etiology. A case in point So since this is a case-based presentation, I thought that the case would actually best suit this presentation, and it will shed the light on why it can be very challenging. So currently is an 18, 19-year-old boy, but he was admitted to Poole Hospital in summer of 2015. He was 12 years old at the time. He came in with a history of vomiting, fevers, body aches, generally unwell. On examination was found to be have some limited mobility secondary to his myalgia. I was very tender on the right iliac fossa as well, with some guarding. He was also noted to have some conjunctival injection. He was started on IV ceftriaxone reasonably, but he continued to spike temperatures even beyond the first 24, 48 hours. That's the period that we would actually hope after starting IV antibiotics to see some improvement on the fever. He went on to have an ultrasound abdomen because of his right iliac fossa tenderness, and that was reported as normal. However, his clinical picture was very impressive, that it actually convinced the surgeons that okay, the ultrasound might not be very sensitive to rule out appendicitis, so he went to a theatre and they had his appendix removed. His initial inflammatory markers were quite raised, white cell count at 25, neutrophils 21, CRP peaked at 116, but his blood culture was negative and his urinalysis and urine culture were negative as well as his viral swabs. So you can really have a focus for why septic focus for why he's getting all these high temperatures. After he got his appendix removed, he actually did have slight improvement, with mild improvement in the inflammation markers as well. White cell count dropped to 19, CRP dropped to 78 from 116, and at that time he also improved even clinically. It was able to mobilize a bit, able to wander about in his room. Temperatures did settle for a period of time, albeit very short, but he was at that point discharged from surgical care. However, his histological examination of the appendix came back as normal appendix. Shortly after, fever started to return again with rigors this time and had liver derangement. ALT shot up to 457 from 13, AST to 192, GGT 199, bilirubin 22, and albumin dropped to 28. And the rest of the inflammatory markers worsened. CRP peaked at 218, white cell count went up to 23 from 19, and neutrophils increased to 21 as well. And he even was delirious at times and required oxygen. Like we said, viral serology was normal, hepatitis screen was also normal, and we did an autoimmune screen as well, which was pending at the time of him getting transferred to Southampton, because we couldn't really work out what could be going on with him. He went into Southampton, but that's not, and he had the treatment there. He was discovered to have Kawasaki, but the only feature that he had from the classic picture of Kawasaki was just the fevers and probably some conjunctivitis, and that was it. So going back to the question, why so challenging? There's multiple reasons. First reason is actually it's reasonably uncommon. I think the country with the highest incidence for Kawasaki is Japan, East Asian, particularly in Japan. And the incidence in Japan is like 10 to 20 times higher than it is in the Western countries. And even there, the incidence is like 200 to 300 in 100,000. So when you adjust that to the Western countries, like 200 to 300 in a million to 2 million, really. On top of that, it's like we said, it's mainly clinical diagnosis. There's no specific biochemical markers for it. Although it is an autoimmune disorder, unlike other autoimmune disorders where you have all these highly specific and highly sensitive antibodies that can rule in or rule out the disorders like lupus or rheumatoid arthritis, that's not present here. There's no specific biochemical marker for Kawasaki. Furthermore, the clinical presentation is still, like we said, it's unreliable in establishing or ruling out the diagnosis because most of the clinical features have a more common pathology, which is probably infection or sepsis, and the time sensitivity of the disease as well. And we will see later that you need to start the treatment within a specific period of time in order to be able to minimize the catastrophic consequences that can happen.
Sorry, just to add a thing, because when you were going through,
Yeah.
this is exactly how children with PMCS are now.
Exactly,
So
exactly.
it's the same thing,
Yeah.
just call it something else because it doesn't have all of the Kawasaki
Yeah.
stuff.
I mean, you think of it as well, other autoimmune disorders as well, especially when you have like other system involvement like liver, GI, as we will see.
One of the things with him, I was here with them when he went off to Southampton, I think it was his age.
Exactly,
Typically
that's
he's
also
older,
atypical.
they're typically
Where yeah, we will have some background
Although PMCS, you
about
would see it like this
Yeah.
in
Yeah.
older children.
Yeah.
And they ended up needing PQ because their blood
Exactly.
pressure was coming and
Yeah.
no one could
Yeah.
like figure out why.
Yeah.
So
PMCS is a multi-system inflammatory response that tend to happen following COVID infection. So that is also a new thing, and that can very much mimic the Kawasaki picture. So it's just some background about Kawasaki. It is a vasculitis, especially of the medium-sized vessels, but to make our lives even more miserable as doctors, it's not specific to medium-sized vessels. You can have involvement of all other size vessels. It can involve capillaries, it can involve veins, it can involve small, and it can involve even large arteries. It can actually involve aorta as well. And it is the most common cause of acquired heart disease in childhood. That was not until a bit recently. Anyone knows what was the most? Yeah, rheumatic fever was number one, but that it took its place. And the exact cause is not yet very known. There is some research that suggests probably there's an infectious stimulus in genetically predisposed children. But what exactly the infectious stimulus, or is that conclusive or not, that's yet to be known. The most common age, as Laura was just saying, is less than 6 years old. So to have a child come in with that is 12 years old coming with these features, and to think about Kawasaki, that is one of the atypical features really for it. And the most severe form of it, the one that has the complications, the cardiac complication, tends to happen in the even smaller children, like the ones less than 1 year old. And it can happen to all ethnicities, with Japan having the highest incidence, as we said, from 10 to 20 times higher than the Western countries. This is a very busy and quite scary picture about the pathophysiology. I'm just going to summarize it very briefly. You have here the inflammatory stimulus that kind of triggers an excessive immune response. We have all these inflammatory cells rushing towards the endothelium of the blood vessels, releasing all these inflammatory mediators, namely interleukins 1, 6, and 9, tumor necrosis factors, endothelial growth factors, matrix metalloproteinases, 3 and 9, and so on and so on. And what that does really is that it induces edema and inflammation in the endothelium, which increases the permeability of the endothelium for these cells, specific inflammatory cells, to infiltrate into the deeper layers of the blood vessels. And that ends up releasing even more of the inflammatory mediators. All this ends up with further inflammation to the deeper layers like the intima and the media, probably following with even medial necrosis can go as far as causing medial necrosis, splitting between the internal and the external intimal layers where you have aneurysms. And when you have problems with the endothelium, of course, you'll have platelets come in to aggregate, and that will might give you thrombosis as well, which can end up with even myocardial infarction. So you basically, the cardiac complications can be thrombosis with myocardial infarction as the end result, or aneurysm, and the aneurysm can also cause thrombosis because of the disruption of the blood flow, or can just rupture and causes cardiac tamponade. The most vulnerable vessels are the coronary arteries, and that is why it's very, very important to address that as early as possible. So moving into the clinical presentation of Kawasaki, I think we can go now. This is a very nice picture, which actually shows you how difficult our lives is with Kawasaki, because you see here the onset of the symptoms, of the different symptoms and signs, and it's not really, they don't really tend to all present at once. So you've got the fever, which is the cardinal feature of it. This is a very famous picture of the full picture of Kawasaki. Well, let's go into this. So you either have the full case, which is very uncommon. It's even more uncommon to present like this, where you have the fever, and the fever is usually, I don't know where is the, there should be a 5 there, 5 days there, sorry. So you have the fever, which usually it's in the textbooks it's defined as 38 or more, but it's usually in the higher side of the fever scale. It's 39 and 40. That's the more common presentation in the case of Kawasaki. It needs to be 5 days or more, and at least 4 of the following 5. Conjunctivitis, which is the most common presentation, actually, tends to happen in more than 90% of the patients. And the conjunctivitis, there's some clues that can point you towards, is it a conjunctivitis because of Kawasaki, or is it conjunctivitis because of an infection? The conjunctivitis of the Kawasaki, it's bilateral, and it's painless, and it's non-exudative. And it's usually bulbar, means that it involves the eye conjunctiva, not the eyelid conjunctiva, and it's limbal sparing. The limbus is the junction between the cornea and the conjunctiva. So as you can see there, there's no really involvement of the limbus. That's the meaning of limbal sparing. The second is the cervical lymphadenopathy, and it's usually, but again, this is not written in stone, of course. It's usually one solitary nodule, tends to be a bit painful, and the width is more than 1.5 centimeters. And then you've got the rash, which can take several forms, actually. It mimics a viral infection rashes, which is macular or maculopapular can happen as well. It's typically diffuse. One point that would actually point against it being due to Kawasaki is if the rash is vesicular or crusty. The rash is actually more common in the groin area, so it's very important to these children to strip them down completely and have a look in the groins, and also in the perianal area as well. We should do this comment there if it happens there. Then there's the mucosal involvement. So you can see it also doesn't have to be that bad, really, but you can have just diffuse erythema of the oropharyngeal mucosa. You can have some cracked lips or bleedings. You can have strawberry tongue with its distinctive fungiform papillae. And then there's the fingers, toes, palms, or soles involvement, which in the acute phase, which is the first 1 to 2 weeks, if you can go back to this In the acute phase, it's just erythema or swelling, but then as you go to the subacute and the chronic phase, the nail changes with discolmation and peeling off the starts in subungual area start to happen. Then you have the biggest challenge, which is the incomplete picture of it. And this is actually the more common presentation of Kawasaki. It's less likely to present in the full picture. So you've got the fever, so the fever is the hallmark, is the cardinal mark of Kawasaki. You've got the fever, which is going to be high fever as well, but it doesn't have to be for 5 days, probably 2, 3, 4 days. Actually, the American Heart Association guidelines recommend starting treatment of the fever by day 3 or 4 if you have a suspicion for Kawasaki. And of course, you will have less than 4 features because it's incomplete. But there is some certain points that can bolster your suspicion in the diagnosis of Kawasaki, which is, this is a patient that has presented, you started him on antibiotics, 2-3 days, fevers haven't really settled, and you have looked for everywhere else for a cause of that septic or of that fever. You've done blood cultures, you've done viral swabs, and there isn't really a cause there. So there is that at that point you should have that in the back of your mind. Could that be Kawasaki? So a lack of alternative diagnosis is a point towards Kawasaki. And in the meantime, you've got inflammatory markers that aren't really settling or improving. There are other features that its presence also points towards incomplete Kawasaki, like irritability without CNS infection. I'm sorry, this is not how the arrangement was. So you've got the irritability without apparent CNS infection and other system involvement as well. You can get hepatic, renal, GI dysfunction, as in the case of Finley. You can get urethritis, vulvitis with sterile pyuria. You can have CSF pleocytosis, again without CNS infection. You can have the perianal and the perianal erythema and discolmation as well. All these are quite common and incomplete Kawasaki.
I think this is really, really great and lovely in theory, but
Yeah.
in real life, how
Yeah.
often do we do this? I mean, come on, everyone that we see
Just
has
makes you-
fever for 3 days. Yes, I guess the only thing is lack of alternate diagnosis.
Yeah.
You can't find it, but
Well,
who would,
How many ones of 4-year-olds can you just go?
yeah.
"No, you don't need a you don't
Well,
need
no, you
a
don't, because it's
source."
virus.
Yeah,
so-
exactly.
So especially after
And-
3 days.
yeah, I'll give you another I'll make your life even more miserable, and I will tell you, in a recent study, it was found that 40% of the patients that had Kawasaki, they were positive for respiratory viruses.
Right.
So even when you have a source, an apparent source of the fever, that does not rule out the possibility of
Yeah,
Kawasaki
but I mean,
as
there's
well.
other things that you need to consider, and I think also, you know, again, presence of other features, including irritability. I mean, every child is, I think irritability is something that people use as a reason for many things, but it's not irritable. True irritability is, I've got, you know, my worst
Cerebral
headache, my
irritation.
worst
Yeah.
pain ever, and I'm not gonna settle. So if you have a child that is truly irritable, you're not gonna let him go home, are you? Like, you're
Yeah.
gonna.
Yeah,
you're
that's
gonna
so.
treat, you
Yeah,
know,
that's so. That's the point. He's irritable. He's going to be admitted. You're going to probably work up why he's being irritable, and if
Yeah.
you don't find a cause for that, that is a
Yeah.
point towards probable Kawasaki.
It does make you wonder how many we miss.
Exactly.
Loads.
Well, I mean, that's hundreds probably.
But
I've
that also
been
shows-
diagnosed Kawasaki's and
Yeah.
No, but
Yeah.
none of them have come back dead.
Exactly. So it
actually
is.
the coronary.
It is in the large.
coronary
It is in the
cause.
large part of it. It is self-resolving in the large part of it, and most of the patients will go on resolve without really having any complications. But I think a safe point to say, if the point of fever extending beyond 5 days, that is a very important thing, because the fever actually can go up to 4 weeks in case of Kawasaki if it's untreated. So an extended time of fever. In the same time, you don't really want to safe net them that the fever can go more than 10 days or 5 days, because you need to start treatment within the first 10 days. This is the safe period of time that if you start treatment, you're more likely to end
but
up without.
If you look at the peer guidelines for
Mhm.
Kawasaki, in the atypical or incomplete Kawasaki, because I'm just thinking about that kid from last week from the night shift.
Yeah.
So we've done the bloods; they were completely normal.
Yeah.
So the question
So it's
then.
not Kawasaki.
Exactly.
So then the question
So-
is, did he really have? So I guess actually digging into how many days of temperature, that's so important. Taking
Yeah,
that history
yeah.
is so difficult because parents will say yes, he
Exactly,
had a temperature
yeah.
every day. Right. Well, how high was it? 37. That's not the temperature. I don't care. Was there a break? Was there a day in this whole
Yeah.
10 days where he did not have a temperature above 38? Yes. Then the clock restarts and then it's not 10 days. It's actually 3 or 2 or whatever. And then that kid had normal bloods. And if you look at the
Exactly.
guideline, it says if you have a quite high clinical suspicion because the fever's been going on for so long, then you should do serial blood
Yeah,
tests,
yeah,
which is why I
yeah.
told them to call yesterday. I don't think they have.
Yeah,
If
yeah.
it's still febrile,
Mhm.
because you want to repeat those bloods. They haven't
Yeah.
called. So
Exactly, but it would be also highly unlikely if a patient with Kawasaki that he's on his 10th day of fever to have normal blood.
So then so was
Yeah.
was
Yeah.
there really 10 days there?
Exactly, yeah. And the fact that there's those other clinical features as well that will point you towards probably a viral infection like the crusty
Yeah. And his
rash.
CRP was like 5.
Exactly,
I mean,
the
he had
history
a
of
big
chickenpox
bacterial
in
infection.
school, yeah. So there's some, we can work around it.
Yeah.
So hopefully.
Do you know what? I think that this is an observation over the last 10 years. We are doing much less bloods with
Mhm.
fevers over 5 days.
Yeah.
And I wonder, I mean, when I was a junior, I had no clue why we were really doing it. Probably to make sure they didn't have a raging CRP and
Mhm.
Kawasaki. But we used to get kids all the time that would have to bleed because they've been febrile for 5 days, and we don't do it anywhere near as much. But but also at that time, incomplete Kawasaki just wasn't a thing.
Exactly. Yeah.
So we kind of stopped looking for it, even though it's now a thing. Like, oh no, we've got.
I mean, I
Yeah.
think if you've
We're
got
going to
a
complicate our
child,
life.
if you've got a child with a fever, doesn't matter for how long, and irritability, or
Yeah.
you're worried, you've
These
got
are well children
you
that
know,
used to bleed.
Well,
you know.
yeah, so it's really unlikely they had Kawasaki, right?
Yeah.
Because children with Kawasaki are miserable. I think whether
As
it's
thin,
complete
yeah.
or incomplete, they're just gonna be like they're not gonna be your.
Yeah.
Pepper does not cheer them up.
Exactly. Yeah.
Was a pig.
Yeah, not.
Salt works though.
All right. So moving on how to diagnose. Unfortunately, again, it's mainly clinical, so there's no specific biomarker, but it's very important to maintain a high index of suspicion based on all what we said before. The lab tests can be adjunctive and can be very useful. So in a child presenting with fever, especially if it's prolonged, you will do the very routine workup. The full blood count is particularly useful in that one of the markers for Kawasaki, albeit unfortunately it starts a bit late, is thrombocytosis. However, it unfortunately most commonly starts from the day 10 onwards. So after really the critical period. But at least, yeah, that will bolster it will bolster your suspicion that this is Kawasaki. The CRPs these will be elevated, renal profile, liver profile, in case of other system involvement. Blood cultures as well, the usual septic workup, your viral swabs, and of course the throat swabs for strep infection, which also can coexist with Kawasaki or even can precipitate it. You will need an ECG, of course, in case of just to detect if there's myocarditis or pericarditis or certain arrhythmias, and you'll need an echo, but that can be later. And the biggest takeaway of this is if you have a high suspicion for Kawasaki, you should not delay the treatment for echo. You just need to start it. So moving on to the treatment, the first line really is, and this is just like reason, there will be, patients should have been started on IV ceftriaxone at least, or broad spectrum antibiotic. And then high-dose aspirin, although there is recently a big debate about high-dose aspirin. This is not really a high-dose aspirin, this is medium-dose aspirin. Apologies for that. The high-dose aspirin is 75 to 90 milligram per kg per day. Recent evidence actually points towards against aspirin. Not really against, but there's no rule really in the recent research for aspirin. It was started because of its anti-inflammatory response, but it's mainly the recent research saying that it doesn't really affect these patients having giant coronary arteries aneurysms later, which is the thing that we want to avoid later, because children, the majority of the children that will even develop small coronary artery aneurysms, they will go on, and that these aneurysms will resolve on their own and they will be fine. But it's the giant coronary artery aneurysms, specifically that will measure 8 millimeter or more on the echo, that these are the ones that will need treatment and intensive care. But the recent research is pointing towards that there's no rule for high-dose aspirin in avoiding or preventing against development of giant coronary artery aneurysms.
How did they work that out? Like they just,
Clinical trials.
so they just didn't give aspirin? Because we don't really
Probably.
do this. Yeah, we don't
Yeah.
really do this in children, saying you're not going to get the aspirin,
Oh,
and we'll see if
so
you get a giant coronary aneurysm.
I think no.
You know?
No, I think they were started on the medium dose, and most
So
of
they still
them.
had something.
Yeah.
But they still had aspirin.
That will need.
So it's just
That will need
for
more digging,
medium
but
versus
that's-
high dose. Because I guess why are you worried about
Yeah.
aspirin? Why don't you give? Why don't you want to give aspirin to them? Does anyone know?
Because Ray's syndrome. Yeah. Because of the possibility of Ray's syndrome.
So we accept that the benefit of aspirin outweighs the risk. But I guess yes. I mean, if it's not going to be any good, then but how are you going to test it? Because you cannot not. You know.
Probably because but what you really want is antiplatelet, right?
Well, yeah, exactly.
So
yeah,
maybe other children will start on clopidogrel
maybe yeah.
other than
Yeah,
aspirin.
maybe.
And I think it is another
I think they do that
antiplatelet
only one,
therapy.
isn't it? I think they kind of.
I've seen one or two maybe
Yeah.
starting clopidogrel.
Yeah.
Just to put this into perspective, this is a very high dose actually, although it's called medium dose, but this is a very high dose per day, because even children that are having shunts like cardiac operations and have shunts, metallic or shunts in the bodies, just to prevent the thrombosis of these shunts, we start them on like 2 to 5 milligram per kg once a day. So
Adults
to have
get
that
like 75 milligrams.
a day, yeah.
Yeah, a day.
So this is quite high dose. And this is started in the acute phase and continued until either the symptoms settle, and then they will be put on a low dose aspirin afterwards, or until the inflammatory markers improve. The mainstay of treatment, however, is the IVIG, which is given with 2 grams per kg over 10 to 12 hours. However, again, to make our lives miserable, the 10 to 15% of patients will go on to fail the initial IVIG treatment, and there is some risk factors that make the patient probably more prone to fail the first treatment with IVIG, namely if the patient develops hemodynamic instability, at which point it would be quite useful to start them with some steroids like methylprednisolone or something. Patients under 1 year old, they are probably at higher risk of failing the initial IVIG treatment. Patients that have liver derangement, ALT, specifically if the ALT is more than 100, or if they have thrombocytopenia initially, if the platelets less than 100. In that case, these patients will probably need another dose of IVIG, but the problem is the IVIG doesn't come without risks. It can actually, I think, induce like hemolysis and other side effects as well. So that needs to be taken care of as well. So that is the second line, is either repeat IVIG and consider some steroids in them. There are some emerging agents under research now which are mainly just anti-immune or immunosuppressants like infliximab, pentoxifylline, and axeximab, but we don't have conclusive evidence regarding them as of yet. An important point is to always try to involve the respective teams as early as possible, like infectious diseases, rheumatology, and cardiology teams early. And again, as we said, it's very important to start the treatment within the first 10 days, ideally between day 5 and 7. And this is actually the IVIG was seen to reduce the likelihood of developing corneal aneurysm from 25% to 3%, 3 to 5%. So it's very effective. So, in summary, these are the main takeaways of the presentation: is that Kawasaki won't always present the way you expect, and always think about incomplete or early Kawasaki, and that positive virus swabs does not rule out Kawasaki, and aim to start treatment as early by day 10 and to involve specialties as early as possible. Thank you.
So everyone's got Kawasaki.
Exactly.
I've seen it once. We had it like a month ago.
Yeah, I mean, at one point we had 3 here, I think, at the same time.
It does come in waves,
It
does
does come in
come
waves.
in the winter.
And
Exactly. It is more common in the
More
winter.
in the winter,
Yeah.
and I think there was.
And I think this is a point towards that infection,
Yeah.
especially like respiratory viruses or strep, has a role in precipitating it.
Yeah, and I think
Yeah.
we used to be taught that got connection with like recent strep.
Yeah.
Is that-
Strep infection can coexist as well and can precipitate it. Yeah.
touch fine.
Now they've got PIMS-TS. I mean, PIMS-TS is literally exactly this, but without
Teenagers.
teenagers and having had COVID, but not always. We've
But
had
not
loads-
always had COVID.
Not always had COVID, and then they don't have all of this,
Yeah.
cervical lymphadenopathy or stuff. They just have a stonking CRP. They always go through surgeons. They always get their appendix out, and then they never get better. And they come in with no blood pressure. Or like literally, it was the same pattern with every single child that came to
Yeah.
PICU, and there were quite a few last year.
We didn't get any in London.
Well, yeah, but you don't know if they got to PICU or not.
Yeah, but like coming to general peds or ED, like when I was doing locums
Yeah.
here, there was
Mm.
a shit ton of PIMS-TS either come back from PICU or just stayed away from PICU. But in central London, there was none.
Well,
Yeah.
there must have been. It wasn't like
Croydon had a lot.
It's mainly because it's the same pathophysiology really. It's just
Yeah.
the excessive immune response to an infectious stimulus.
What?
I say it makes sense, Croydon.
Croydon. Croydon had a lot. Croydon had anything.
Oh, because Central London is too posh.
Yeah. Hampton, darling.
Any questions?
Mustard.
Thank you.
No, that's right.
So you get like
Yeah, it was great, Salma. Really
Great,
good.
thanks.
Okay.
Is this because you're cortically scarred because of that lunatic that... Do you know that
Yeah.
you've got
Boy.
incomplete Kawasaki? Because if you tell me that, I'm gonna just...
Which one? The
You know-
small. No, I
You
don't think so.
don't know.
I don't think so.
His blood was fine.
And he didn't have temperatures for